Kevin Flaherty is a professor of pulmonary and critical care medicine at the University of Michigan Health System in Ann Arbor, Michigan. He has a particular interest in interstitial lung disease and was a co-author of the official American Thoracic Society position statement on the evidence-based guidelines for the diagnosis and management of idiopathic pulmonary fibrosis. He is truly at the forefront of this disease state, and we are very fortunate to have him here today.
Thanks, Jan.
Welcome, Kevin.
Thank you very much. It's a pleasure to be here. How do we make a diagnosis of idiopathic pulmonary fibrosis? So the diagnosis really comes down to finding two things. The first is, and I say beyond a reasonable doubt, you have to exclude a cause. And I say beyond a reasonable doubt is because we've all had some hobbies or some occupation where you say, well, there was that time 30 years ago where I inhaled this. So it's really a lot of detective work to try to figure out, is there something that you feel confident enough that that's the cause? Or, yeah, we've all inhaled some things over our lives and this is really not the cause of it and this is a idiopathic disease.
Yeah, 8 years ago I had a parakeet.
Right.
Or my daughter, who I used to visit a lot, had birds in her apartment, and now I've got this, and could that be?
Right, and it becomes very difficult in many cases. The other important caveat is don't give up the hunt for a cause on the first visit. We always think the initial history and physical, we're going to figure it all out, but a lot of times these things show up over time. You know, I live in Michigan, and a lot of our patients come down to Florida for the winter. One of my patients, we found out he had hypersensitivity pneumonia, allergic to the down in his linens. Wow. And he figured that out because when he went to Florida, his cough went away. When he came back, started sleeping in his own bed, his cough came back, and we looked a little bit harder, and that was the cause. So that took months and months to figure out, but it actually changed what we did for him. So detailed history on the first exam, but don't give up. You may find something down the road. The second part of the diagnosis of idiopathic pulmonary fibrosis is probably the most confusing, and that's finding this pattern that we call usual interstitial pneumonia, or UIP. UIP is a histopathologic term. It goes back 40 years to looking under the microscope and seeing a specific pattern. It tended to be the most common, that was the usual. It involved the interstitium and not the airways, that's the interstitial. And I think when pathologists see any inflammatory cell, it's a pneumonia. But it's confusing because our patients read their EMR and they think they have an infection. So this usual interstitial pneumonia is a histopathologic pattern. It can be seen with many different things. You can see with autoimmune disease, chronic allergic reactions of the lung, or idiopathic, in which case it would be IPF. Now the other aspect of UIP, I said it started as a histopathologic term. Then you fast forward over many decades and we started getting these really fancy high-resolution CT scanners. And as we'll talk about in a little bit, there are some features on the HRCT that if those features are present, primarily honeycombing, that's a really good biomarker that if you did a biopsy, you would find this UIP pattern. So usual interstitial pneumonia, or UIP, is a pathologic term. When it occurs spontaneously, it's IPF. And in some cases, probably about a third, you can see features on an HRCT that preclude your need to get a surgical biopsy. That's the diagnosis. Simple to write on one slide, but very, very difficult to operationalize. Other things that we hear on physical exam, and Michael had this, is he had bibasilar crackles.
Okay, so those are very descriptive sounds when you hear that predominantly in the bases of the patient. So just looking at some of the comorbidities here that we see, GERD, smoking, male predominance, if we heard those crackles, should the primary care clinician at that point know other etiology by history or maybe by some simple lab tests, which don't seem to be very extensive here? Is this where maybe clearly better PFTs than just office spirometry with lung volumes, as well as perhaps high-resolution CT if we see that restrictive pattern? Is that the way we should be pursuing it?
Right. When we hear crackles, we want to think beyond asthma, COPD, and obstructive lung disease and start thinking about interstitial lung abnormalities. So more complicated or detailed pulmonary function testing, and then if that confirms there's something going on, getting either a chest x-ray or moving on with a high-resolution CT scan to really see what's going on there. The other caveat I want to make is what we just heard, those were striking. Yeah. And those are classic, and those are definitely, these dry crackles we talk about. So you really have to listen hard for crackles. They're in the base. Early on, they occur at the very end of inspiration. So we need to have our patients take a very deep breath, listen very hard, push our stethoscope really hard against the chest wall to get as close as we can to those lungs, and then you'll hear those subtle early crackles, and you can make the diagnosis early. So we heard great examples of pretty profound crackles here, but they don't always sound that striking. And if you hear just subtle crackles at the end of inspiration, that may be the earliest sign of interstitial lung abnormalities.
So one of my pet peeves is that people are often listening to the heart and the lungs on top of a shirt or an undershirt. I mean, we need to get patients appropriately undressed to be able to do a good pulmonary examination and listen directly on the chest for these sounds.
Absolutely.
Yeah, okay. Okay.
We touched a little bit already about pulmonary function testing, and just to review from what we saw with Michael, we think of lung function testing in 3 different areas. The pulmonary mechanics are the FEV1, FVC. That's typically what we see in the office spirometry. And if you see obstructive lung disease, so if you see that FEV1, FVC ratio being decreased, you've made the diagnosis of obstruction. Right. It's when it's normal or elevated that you start thinking, well, could this be restrictive disease, meaning true low lung volumes? Right. Was it a poor effort? They just didn't breathe out well. Do they have neuromuscular disease? Right. So to sort out that weakness versus effort versus true low lung volumes, that's where the lung volumes come in. So with restrictive physiology, we see TLCs and residual volumes being decreased. And then the last thing we talked about earlier with Michael was the diffusion capacity for carbon monoxide. Yeah. A measure of how much oxygen can get past the alveoli and into the bloodstream. Right. So things like anemia will cause the DLCO to be low. Pulmonary vascular disease, thromboembolic disease, certainly scarring diseases, emphysema. So the DLCO tells us there's some abnormality in gas exchange, but it's very, very, very vague. It doesn't help us narrow down even if it's restrictive or obstructive physiology. Yeah.
So the DLCO there's a problem at the alveolar capillary membrane in gas exchange, and you have to try to explain why it's so low.
Right. So if we work through an algorithm, we can think of IPF, the current approach. First, we suspect it. We don't ignore it. We look for identifiable causes. Right. If we find one, by definition, it's not IPF, and we go down the path of removing that exposure or treating that underlying disease. If we're stuck still thinking about ILD, but we don't have the cause, and this slide actually highlights some of the things that we think about that we've talked about. Is there an infection? Is there systemic disease? Are there exposures, or is it idiopathic? That comes back, and we still think ILD is present. We then go on to imaging. So the cornerstone of imaging with ILD is the high-resolution chest CT, but it's actually okay to even start with a chest X-ray. Right. As we heard about in Michael's case, he had interstitial markings. And if you see a chest X-ray and it has interstitial markings, then you need to move on and do a high-resolution CT
right.
scan. The hard part with chest X-rays, it's not as sensitive as a CT scan. So don't be given a false sense of security by a normal chest X-ray. If you've heard crackles, you suspect restriction, even if the chest X-ray looks mostly normal, there may still be subtle ILD there that you can see on a high-resolution CT scan.
And clearly to tell the radiologist the good history that you've gotten and your exam and what you might be suspicious of will help them on that chest X-ray.
Exactly. Right. And on this chest X-ray, so what we see here are the lung volumes are small. That's restrictive, so there's some scarring going on. I'm not sure how well it projects, but there are peripherally based interstitial abnormalities. That doesn't tell us what is going on, but it tells us that there's something there that shouldn't be there. So he's got some interstitial lung disease, and if we saw this chest X-ray, that's when we would say, oh, we need to do a high-resolution CT scan. Our differential diagnosis just became more narrow. We're no longer thinking about thromboembolic disease and pulmonary embolism or a lung mass or cancer. Sure. So we don't have to use contrast to do the PE protocol CT or a malignancy scan. We can do a high-resolution CT scan, which, as we talk about in a few minutes, doesn't have contrast. It has very specific algorithm. And that's on this slide here. So a high-resolution CT scan basically means that it's a non-contrast study with very, very thin slices. The thicker the slices, And you could think of a chest x-ray as the broadest example. However thick that slice is, every type of density pattern in that slice thickness gets averaged out and displayed. So the thinner your collimation is, the less different types of density patterns are in there, so it can be much more crisp. So that's what accounts for that very high resolution that we see with an HRCT. The slice thickness is typically 1 millimeter or less. It does not use contrast, so that makes it easy in terms of patients that might have renal insufficiency or drug allergies. It uses specific windows to make the edges show up very crisply, so we again get that high resolution. And the other thing that's often done, particularly if we know ahead of time, and this gets at your point of telling the radiologist what you're thinking about. If you say, I'm really thinking about ILD, they can do expiratory images, which help us figure out, is there air trapping? We see the inflammation and allergic reactions often around the airways, and you get a little bit of air trapping sometimes, and we can see that on the expiratory images of CT. Or prone images. One of the hardest things to determine is early interstitial lung disease abnormalities. Is it just some posterior atelectasis, or is it early ILD? And if you prone the patient, you turn the patient 180 degrees, and that goes away, it was atelectasis. If it stays there, it was early interstitial disease. So knowing what you're looking for, talking to your radiologist about your differential can really help them get you the best scan that's possible. If you're looking for cancers or thrombotic disease, those are more contrast studies and they're not a high-resolution CT.
You know, I just wonder how many primary care clinicians have ordered a high-resolution CT in their clinical practice.
And it's hard, even in referral patterns. We can talk a lot here and talk about the importance of HRCT, but again, if you really take a step back, a lot of times where we're starting from is a very broad differential diagnosis.
Right.
And you start with that PE-CT, which may show you something because you're worried about a lot of different things.
Yeah.
But once you narrow it down to saying, I know the patient has ILD and I'm following them, or the chest x-ray shows those interstitial changes, then you can kind of up front order this test and not worry about the contrast.
At the very least, I think more people are going to be thinking about should they be ordering a high-resolution CT in the future than they have in the past. Okay, let's keep going.
And this slide shows those features of usual interstitial pneumonia. I mentioned UIP is a pathologic term, but in some cases we can see features on a CT that tell us if we did a biopsy, UIP would be there 100% of the time. And those features are on this slide. The distribution is worse in the lower lungs and in the periphery. That fits with our physical exam. You see here the crackles in the lower lungs. So the disease is worse there. You see interstitial lines. If you look at the outside of a lung CT scan, that last centimeter around the periphery should be clear. So if you see little things coming in there, that's some abnormality.
Subpleural.
Now this is a really striking case. This has a lot of abnormality, and you see really around the periphery what looks like a bee's honeycomb.
Yeah.
You know, like you cut a honeycomb of it. That's honeycombing. And that feature, when honeycombing is there without other things, it's just really honeycombing like that, that's the feature that we say is pretty much pathognomonic for a biopsy that would show UIP. So this CT scan is a UIP pattern. It's peripheral, lower lobe, with reticular changes that include honeycombing. And actually, if we look at some coronal images, you can really see strikingly this distribution of disease that really is peripheral and lower lobe predominant.
Yeah, very important. So let me just, a couple of questions from outside real quickly. High-resolution CT is not ordered in our hospital setting. Is it very expensive?
I'll plead ignorance on the insurance side of things. I would imagine that a high-resolution CT scan is the same cost as other types of CT scans, but I don't know that for a fact. And
I would really feel comfortable insurance would cover it in the right clinical setting as we're describing here.
Occasionally we need to argue for it. So occasionally a patient will be referred to us who's had a PE protocol CT. We know that it shows some abnormalities, but there's other things with a PE CT, for instance. The thing that the radiologist cares most about is the timing of the contrast bolus. So while they're focusing on the timing of the contrast bolus, the patient may breathe, and we get motion artifact that makes it a little bit blurry. So we may want to order a high-resolution CT to really clarify that, really get a good breath hold and get those crisp images. We will sometimes get pushback from insurance companies saying they just had a CT. But if we actually make the phone call and say, listen, what we're trying to do is get detailed images that may prove that we can prevent a lung biopsy, usually they'll come back and say, okay, there's a reason you're doing it. You're just not ordering the same test. You're actually ordering a different test that happens to be called a CT scan.
Two questions are the same, and that is, can you see COPD and interstitial lung disease at the same time?
Great question. We mentioned that one of the risk factors for interstitial disease, for idiopathic pulmonary fibrosis, is smoking. And you can see mixed patterns. You can see patients that have emphysema in the upper lung fields and interstitial changes in the lower lung fields. It's a really important concept to think about, because if you look at the pulmonary function testing in that patient, because of the obstruction from the emphysema and the restriction from the fibrosis, their pulmonary mechanics, their FEV1, FVC, and their lung volumes actually average out and are normal.
Ooh.
The tip-off is their DLCO is really low. So again, as you are thinking down this pathway, you're a smoker, you heard some crackles, and you do your spirometry in the office and it's normal, if you're still thinking, that's when you do those more detailed testing and see if the DLCO is there, get the imaging studies.
Yeah.
So it's a really, really insightful question.
Are patients with pulmonary hypertension earlier to get pulmonary fibrosis?
They're not. I mean, it's actually in patients with more advanced pulmonary fibrosis and hypoxemia, we tend to see secondary pulmonary hypertension, but they're not the same disease process.
Okay. And then has HRCT replaced bronchoscopy?
Yeah, so with idiopathic pulmonary fibrosis, we can't get enough tissue with a transbronchial lung biopsy. So there's some diagnoses like sarcoid or infections and malignancies. We're very good at getting the answer with bronchoscopy, but for IPF, we just don't get enough tissue. So HRCT, in about a third of cases, precludes the need for a surgical lung biopsy, but we don't really use bronchoscopy for the most part to try to make a diagnosis of IPF.
And that's done within thoracoscopy, and sometimes they're not even hospitalized from, just for 23 hours and out.
Yeah, we usually, we actually did those as outpatients for a while. We tend to keep them now for a day or two just to be on the safe side.
Okay. Well, Kevin, I want to thank you for a great
My
talk.
pleasure.
It's taken a complicated area and really made it clinically applicable and manageable. I'm sure it's going to help all of our providers, our clinicians out there.